Great. Thank you, everybody. Good morning. It is my absolute pleasure to introduce our next speaker for the Professional Development Committee's second Tech Talk for this session. Dr. Neff and I first met in October of 2013, and I'm not sure if he remembers that case, but we're in Bagram, Afghanistan, taking care of a 12-year-old girl with a rectal vascular malformation and chronic anemia. And since then, he's done extensive work, and I'm so proud to see how much his career has developed over that time. Following that deployment, he did extensive work with the Joint Trauma System, looking at balanced resuscitation and transfusion therapy. He secured extensive DoD funding as a medical innovator and is an expert in balanced transfusions and resuscitation. And I look forward to hearing his talk today on TEG and how we can use it in the pediatric surgical world. Thanks.
Thank you for that talk. Is this working? And if anybody's seen the Brene Brown TED Talk, you know that one of the things that she says, and I recommend it to you, she says, you got to lead with vulnerability. And so I'm going to do that. I've got two confessions for you today. Oh, there we go. All right, two confessions today. Confession number one is I'm absolutely the wrong guy to be giving this talk. As I was asked to do it, I said, oh, sure. Then I had this realization, I don't utilize TEG nearly the way I should. I'm a level 1 trauma center medical director. I think a lot about these things. I think a lot about blood, and yet I don't use TEG that much. And I didn't know much about it. So this is a series, this is a journey I'm going to bring you on with the things I've looked at in the literature, the conversations I've had with my adult colleagues and people around the country. And so I'm going to bring you on that, but I'm not the guy. So out of the gate, sorry to disappoint. I do have one challenge to you, though, and this is the very simple challenge. I want you to go back to your home institutions and simply ask the question, do we have a TEG machine? You may get some blank stares, right? Let me get through some of this other stuff. I don't have any disclosures that are relevant. I don't work for Humanetics. And so that's my question to you. Do we have TEG? And, if you're a level 1 trauma center or any kind of designation through the ACS, they mandate that you have some way to assess coagulopathy for patients that are being transfused. It's a requirement. It's a type 1 deficiency, so it's important. The other thing about this, as I started thinking, it gave me the opportunity to go back and think about a tough case. And that's part of confession number 2. And many people have seen this quote before. I'm not going to read it to you. But this gave me the opportunity to go back to my own little personal cemetery and revisit a really tough case. And so we're going to get into that in a minute. So what is TEG? Well, thromboelastography is a point-of-care test using whole blood to provide a real-time graphical assessment of the entire clotting process, from the initiation of that clot, the stabilization of it, and eventually even the breakdown of that clot. And it gives you this dynamic picture of hemostasis, much better than PT and INR can offer us. And if you're like me, there was some common objections as I started to think about TEG. Number one is it takes too long, right? It's going to give me this tracing that takes 45 minutes, an hour to completely play out, and maybe it'll end up in the EMR with some numbers I can't interpret. It takes too long. And in a dynamic resuscitation or situation, you're well past that point now. The other issue is that I can't keep all of the different tracings in my head. Is it a wine glass? Is it a champagne flute? Is it a whiskey tumbler? I can't remember all that stuff, particularly in the heat of the moment. And so that was another objection. The third one I think is the most realistic for all of us here, which is like, where do I get that information? Can I see it in real time? I don't want it to populate in the EMR 3 hours later when it's not helpful. In the logistics of going to maybe a different site within your server, it's not in the EMR, and to see that tracing develop, how do we do that? Some places have figured that out, some haven't, I haven't. And so those were my objections, but the reality is that within the first 5 minutes of that TEG being run, you can have actionable data that can make a difference and help drive decisions. Between 5 and 10 minutes, it's super fast. There is also a lot more integration now with the various platforms to send that TEG tracing to your phone in real time. And I know this is happening because my adult trauma colleagues are doing it all the time. They pull their phone out in the heat of battle and they're watching that TEG. And more than that, what they're watching gives you the tracing and clinical decision support. Hey, this variable is low, consider this. So they're not having to remember all those things. That cognitive overload is not an issue. So confession number 2. Early on in my practice as a pediatric surgeon, I was called to the emergency room early in the morning, 14-year-old, gunshot wound to the groin. Obviously in hemorrhagic shock, we quickly start the resuscitation and get him upstairs. We're transitioning him over to the OR bed. He arrests. We open his chest, clamp his aorta, pouring blood in him, get him back, laparotomy. We discover that the gunshot wound entry point's here, but he has destroyed his left iliac artery and vein. Laparotomy, get control. There's a lot of things I would have done differently. I'm really proud of our anesthesiologists for one-to-one therapy. They got 60 units in them, a really balanced resuscitation. I made decisions that caused us to spend too much time in the operating room, but when we rolled out of the OR to the ICU, we were thumping our chests because we had a patient that was warm, whose base deficit was correcting, and was making clot. How could TEG have influenced that resuscitation? Here's my confession number 2 is we did not use TEG. We did not use TEG to guide that resuscitation. How would it have influenced it? So I started digging in the literature, and there's not a lot on the pediatric side of this, a lot of adult data on TEG, but pediatrics a little bit skimpier. I did come across a paper by Adam Vogel at Texas Children's, and this was written like 10 or 15 years ago. And what they did was they looked at TEG parameters compared to standard coagulation tests that we would get. And they saw a pretty good correlation. But the thing they did that was so smart is they said, okay, let's take these various parameters of TEG and do they correlate to life-saving interventions? Are these TEG parameters going to tell us downstream whether or not they're getting some type of emergency surgery, et cetera? And so what they found was that the maximum amplitude, the width of that TEG tracing as it's developing was the most predictive of needing a life-saving intervention because that speaks to the relative strength of the clot, actually, and the contributions of platelets and fibrin to the strength of that clot. So I had that bouncing around my head, but I still didn't know where to go with this talk, and so I picked up the phone and I called John Holcomb. And many of you may know him. He's a pretty well-known adult trauma surgeon, been in the military, has led a lot of important trials on resuscitation, has thought a lot about TEG, and I said, John, you got to help me. What do I need to tell all these people as I look out here? And he said, honestly, I think the thing you need to tell them is they have to pay attention to the maximum amplitude. And I was like, oh, great, I just read a paper about that. At least won't sound like an idiot. And he said the maximum amplitude is important because it keeps you in touch with the redheaded stepchildren of resuscitation, which is platelets and cryo. Because everybody forgets about those or they don't give those enough. And what it tells you is that clot's not strong enough because you need more platelets that work, that don't suck, and you need cryo for that fibrinogen. And so I thought that was interesting. I said, well, what else can you tell me? When do we use it? Do we need it right at time 0 when that patient hits the trauma bay? He's like, no, I think the most important time to use TEG is as you are rolling up to the ICU. You've stopped the definitive hemorrhage control. A lot of this is going to be coagulopathy of trauma that you have to address. This keeps you in touch with your need for platelets and cryo, but get that TEG on the way out of the operating room, something that we did not do, right? And so what he couldn't address, though, is TEG's expanded role beyond just trauma. And this is something I'm learning even recently. Using it for the neonates before their stoma takedown after NEC or their lysive adhesions. Using TEG preoperatively to optimize those patients and transfuse them with plasma if they need it to hopefully minimize some of that ooze that we all encounter in our tiniest patients. And then over the ECMO, right? We all have patients that are systemically anticoagulated with bivalve or unfractionated heparin, but there are bleeding issues that are happening in that dynamic process above and beyond what a PT-INR and a HEP assay can tell you. And TEG can potentially give you some actionable data. And moreover, those two scenarios I just mentioned are much more common than a massive transfusion. So building that muscle memory, starting to use TEG to do that, is actually something that will, all boats rise with the tide and will help your team be more familiar with it, have you the ability to access it in a pinch. And so those are two things he didn't speak to, but I think is really important for us to understand. Back to my confession. Okay, so we get up to the ICU, again, thumping chest, slapping butts, high-fiving. We've just pulled this kid out of the fire after a massive injury. And about an hour up in the ICU, guess what happens? The vac canisters start filling up, and they don't stop. And we re-explore his chest, his abdomen, not once, not 3 times. We're back in there. We're looking for anything we can find to stop these vac canisters from filling up. And at this point, intermittently, he's a little bit awake. His mom's there at the bedside. He's communicating with her. And we are pouring blood products in. And I'll never forget this. It was about 6 o'clock, so maybe 14 hours after. And we are up to product number 120, 130. The blood bank is exhausted. We're all exhausted. This young man is exhausted. And we had to go to the parents. And we have all been there, right? Said, we have to stop. There's nothing else we can do. We've thrown the kitchen sink at him. Didn't use TEG. And that's something that I have to think about when I go to my little cemetery and visit that patient and that young man and his family. And so, anyway, just in closing, I would say there are a lot of expanded applications for TEG. We need to be thinking about it, and I would charge you to go back to your home institutions and just ask that question. Do we have TEG? And use that as a jumping off point for conversations with your intensivists and with your anesthesiologist, with the ED even, with your lab, to understand how you can integrate it into your workflow, particularly not just for trauma, but for these other kind of quasi-elective indications that are for your patients on ECMO. And I think we owe it to our patients to take the best of what's out there in the adult world and start to apply it and figure out how we can actually operationalize this in our own practices. So thank you for your time. Happy to answer any questions.
I think we have a question from Dr. Russell.
Thanks, Luke. That was fantastic. I just wanted to put in a plug for the MEDIC-2 study. That's actually going to give us some TEG data on patients that are getting massively transfused. So those that are participating, keep participating, and those that aren't, look for that data.
Thank you. I actually was talking to Dr. Russell yesterday, and I said, hey, if I forget to mention MEDIC-2, please do. So thank you for doing that. Whole blood versus component therapy, TXA versus placebo, those are essentially the way that study shakes out. It's a big study. There's about 22 centers participating, and TEGs are being drawn at time 0 and at 6 hours. And I think that is going to be, it's a very well-designed, very expensive, very complex study, but that's going to give us a lot of information in the pediatric trauma population for massively transfused kids. So that's coming down the pike, probably a couple years down the road. Thank you.
Dr. Rosen?
Yeah, a great presentation and a very important topic. And looking back, we went from giving fresh whole blood, wholesale or to it's hard to store and we got to fractionate. And then some of us, I graduated medical school in 1994, and the criterion standard was component therapy. And so, we learned from, an early experience in Iraq that if you give whole blood, it's great. If you can't give whole blood, people got the lesson of 1-to-1-to-1 ratio of product. But the more we learn about what that experience is like, well, if you don't, you can start out 1-to-1-to-1, but if you don't look at TEG, you don't know where to go. And you will be in a very haphazard fashion. And really, we have a small number of patients, the adult population much bigger, and they've really reliably shown some discrete phenotypes of coagulopathy that are very, very different than one another. And so if you have this idea that the coagulopathy is all the same, I just got to throw the kitchen sink, well, you're going to have more people in that little graveyard. So very important, great work, and I hope that everybody takes this home and says, if I'm not doing TEG, how can we do TEG, and how can we make this work in my organization?
Yes, I see your comment, and I'll raise your comment. I do think that's exactly right. Obviously, this was not a talk where we could get into fibrinolytic shutdown, and all those kinds of things. There's a lot that happens, and a lot of actionable data that you start to get as that TEG tracing unfolds. Ask the question, do we have TEG? For those of you that aren't in freestanding children's hospitals and you can rub shoulders with the adult trauma surgeons, do that and start to see, have them pull their phones out and show you the tracings and how they operationalize that, and then really start to utilize it in these quasi-elective cases too, just so that we're getting more familiar with it. I think that's something that we in the last week have even used several times for a very difficult neonate, and that's been a difference maker for us. So do you have TEG?
Dr. Healy, last question.
Yeah, thank you. I guess I'd start with a disclosure. I'm also a transplant surgeon, and we've used TEG in the operating room for a long time. And the key things, it tells you a lot about clot strength, and which is entirely different from what the INR and PTT tell you, because those tests end when the clot starts to form. So it's a complementary test, and I think just in terms of utilization, I think your recommendation about having a visual available during the course, you don't have to wait 60 minutes for the test to be fully complete to use it, and seeing it in real time tells you what you need to know in the first 5 minutes exactly. So I'm really glad to see this working its way from the transplant community into trauma and other environments, but it's probably the most important intraoperative test where you're worried about transfusion and bleeding, in my opinion. So thank you very much.
That's a great comment, and you don't have to memorize this slide because even in the first 5 minutes, you're starting to get some actionable clinical decision support from a lot of the software platforms that are out there now. So it will guide you.
Great. Awesome. Great. Thank you all. All right. Thank you, Dr. Neff, for an outstanding talk. We really appreciate it from the Professional Development Committee as well. We appreciate your time.